introduce you to our speaker today, Dr. Nundy. Dr. Nundy is a primary care physician. He is the Chief Medical Officer for Accolade, which is a healthcare navigation company, a very good one, and advisor to the World Bank. But you know him because he is the author of Care After COVID. And that is the book that, if you want one, is being passed around to you today. It's an excellent book. And I'd like to introduce Dr. Lori Rice Spearman at the head of the table, who is our president of the Texas Tech University Health Science Center, and the rest of the people that are here assembled, and some of them which are online, form the president's cabinet. The president's cabinet are the academic leaders of the university and set policy and work on various strategic planning initiatives that are important to our future, one of which is comprehensive telehealth. And we are very happy that this important and seminal work is what we'll hear about today. And you all know of this book because we mentioned the key points of it in our recent strategic planning meeting. So thank you all very much for allowing us to bring this opportunity to you as an important way to move the university forward on our strategic plan. And with that, I'll stop and we can go forward with the rest of the program.
Next slide. Quick acknowledgement. This educational activity is brought to you by Texas Louisiana Telehealth Resource Center, which is headquartered in our institution. It is a federally funded program with F. Mary Hall and Community Health Center, as well as with Well Ahead Louisiana, with generous support from HRSA. TexLa is one of the 12 regional TRCs across the U.S., together with the 2 national TRC, the Center for Connected Health, who is based in California, and Technology Assessment Center, which is based in Alaska. The 12 TRC and the 2 national TRC form the National Consortium of Telehealth Resource Center. Dr. George?
Yes, there are some etiquettes. Everyone should be muted. Also, kindly type in your name and email into the chat box, as well as the questions and comments. We will entertain questions at the end of the presentation. And now I pass the baton to Mr. Majors, and he will be introducing our speaker of the day, Dr. Shantanu Nundy.
Thank you, Dr. George, and good day, everyone. Hope everyone's looking forward to this as we are. We've been anticipating this day for some time. Dr. Phillips made some introductory comments about Dr. Nundy, and I appreciate that. Let me elaborate a little bit. I became familiar with his work when I listened to a podcast with Senator Bill Frist, and I enjoyed that very much, and then purchased the book and distributed to some of our opinion leaders here at the Health Sciences Center. So this is a great occasion, in my opinion. Dr. Nundy is a practicing physician. He works in the Washington, D.C. area. He's a primary care physician. I believe Dr. Phillips mentioned that. He also worked with the World Bank, which was mentioned. He's been the director of the Human Diagnosis Project, health artificial intelligence startup, which he successfully built on the world's largest open medical project spanning 80 countries. He's also co-inventor of SMS DM Care, and he may explain a bit more about that during his presentation today, but it's an automatic text messaging software system for individuals with diabetes, one of the first mobile health interventions to be adopted by the World Health Organization. He's a much sought after speaker, and we're very pleased to have you, Dr. Nundy, here at the Texas Tech University Health Sciences Center. And so we'll turn it over to you. Welcome, sir.
Oh, thank you so much. Thank you so much. It's very, very, very kind. And I really appreciate this opportunity. It's really great I always value the chance to talk to frontline providers and teams. That's really where my heart is. You know, I've done a bunch of different things, but my happy place is every Friday when I get a chance to see patients at this federally qualified health center that I work at in DC. So it's great to be amongst colleagues. So thanks so much for this opportunity. So I'm going to share my screen here. Technology will be my friend today. Oh, look at that. All right. Well, you know, the title of my talk is Never Waste a Crisis, right? I think that's very apropos for, I think, the place we find ourselves in. I don't think any of us would have wished that we would be in the predicament we all find ourselves in today. But just like we found in our personal lives that there's a silver lining to some of this, I think the same can be said for healthcare. And I think that's a really important story that I don't think a lot of frontline providers have had a chance to hear. And it's a story that we can actually act on. And so really my goal in the presentation is to really convince you of a couple different things. I think the first is somewhat of a provocative statement, which is that I think healthcare's changed more for the better in the past 18 months than it has in any 18-month period in its modern history. And it certainly doesn't feel like that, I think, to practicing physicians, but hopefully you'll see some evidence of why that's true. I think the second point, and I'll admit this is optimistic, but I think we have a choice. I think we have a choice where I think if we look back, 10 years, 20 years from now, at this moment, we'll remember, clearly the tragedy and the loss of life and the burnout on the front lines. But I think we have a choice now where we could also look at this as a moment where a catalytic moment where healthcare really started changing for the better. And that's really the second, I think, objective of my talk, is to sort of convince you of that point and to say, well, what does this mean for us? Those of us that still practice, those of us that are passionate about technology, serving the underserved, what does that exactly mean? And so that's really where I want to take us through. So I'm going to start by just talking about what COVID revealed. I think, we've all lived it in a lot of different ways, but I think sometimes it helps to step back and say, well, what are some of the things that we kind of notice on a more national or even global scale? What's changed? I said things have changed more in the last 18 months than our history. Well, what exactly has changed? And then I don't think any of us are happy with where the system is. I don't think the argument is we've made it. I think the argument is we don't want to go back to the old normal. The current new normal that we're in isn't enough. So what is the answer? What is the vision for where healthcare needs to go? So not at all a lofty agenda for us here today. Let's start with what COVID revealed. And some of this, what I'm going to highlight is really the sort of system factors, that sort of famous quote that every system is perfectly designed to achieve the results it gets. Well, I want to start digging into those system factors. So the first, really interesting thing that happened, and this is data from the Northeast, but we saw this data nationally, is that as COVID started, even in the early months, we saw the hospital stays drop. This is data looking at acute cardiovascular conditions, largely heart attacks and heart failure. You see admissions drop, and you also see significant changes in total and cause-specific cardiovascular mortality. So sort of the first question to ask ourselves, well, that's interesting. Why is that happening? Why is it that when we have a viral pandemic, why is it that it's affecting the rate in care for people with acute heart conditions? Well, why is that? And I think part of the argument that I'll make is that it has to do with how we design our system, right? That sort of the classic analogy is, if you put all your eggs in one basket, if the basket breaks, all the eggs break. Well, when we rely so much on care in a hospital, we rely so much on care in a clinic. Well, when that clinic or hospital is overwhelmed, when there's not enough equipment, when there's not enough staff, or there's not enough beds, well, guess what happens? And I think that's a real argument that I'll make for why we need to distribute more care, outside of these acute settings, so that we have a more resilient system. The other thing we saw, and I think a lot of us that are in primary care saw this pretty dramatically, was that vital care was missed, right? So you see, as the pandemic started, this is data from early 2020, the huge drop in ambulatory visits. As people were told to shelter in place, people were scared. Some doctors' offices closed, some went under. And some colleagues and I wrote this up as sort of the second hit of COVID. It's interesting if you look at even the Ebola crisis we had in West Africa. I was at the World Bank at the time. As many people died during the Ebola crisis from HIV, TB, and malaria, increases in HIV, TB, and malaria deaths than they did from COVID. From Ebola, and that's because of the disruption to sort of usual care. And we saw that dramatic decreases in cancer screenings, dramatic decrease in vaccinations. Some people are saying we're going to see the impact of this for decades. But again, we have to ask ourselves, why is that? Why is it that we've designed our systems in such a way that when a viral pandemic comes our way, why is it that it's impacting preventive care? For example, if we did more colon cancer screening at home, mailing people fit cards, maybe that wouldn't be the case, right? Because we would have a system that inherently put their eggs in multiple baskets, right? Care would be distributed to many places. And so just because one clinic's overwhelmed or one hospital's overwhelmed, it doesn't necessarily have to mean that preventive care goes down. If we measure people's blood pressures at home, if we did more home visits, all those kinds of things would make our system inherently more resilient than relying on fixed facilities like we do in our country today. Perhaps the most sobering, I think for many Americans, I think those of us in healthcare have known this story for a long time, whether you're talking about maternal mortality, infant mortality, whether you're talking about rates of diabetes or complications thereof, that healthcare is far from equitable. And I think for a lot of our neighbors, it was devastating to see how true that was for folks of specific marginalized populations. And I think for many people, this idea that COVID was a magnifying glass, and it's a really powerful analogy, right? That the system was already broken, but now we were magnifying it by stressing it. We were able to see the fractures within it so much more clearly. And I think this is perhaps the most sobering. And so part of what my argument is that, you can look at these service level factors and say, okay, well, these things happen, but the question is why, as I started to tease, right, is part of it is this over reliance on physicians and clinics. So let me give an example. Early in the pandemic, my colleague and I wrote a piece about how we should test people at home, that people should be able to swab their own nose and test themselves for COVID. We wrote that paper within the first 4 weeks of the pandemic. And I will tell you that I was lampooned for that article. But really the argument I was making was very much an equity point that, look, if, we know 20 to 40% of Americans don't have a doctor. We know many people live in health professional shortage areas. We know many people have a hard time getting to clinics because of their work and family lives. We know that some people can't afford it. Well, the moment you require a test for someone to get a test, you require that they are seen by a physician, which is, remember how it was in the early days. By coupling care with the physician with testing, you fundamentally made that testing inaccessible to many, many people. And that's something that we do over and over and over and over again in healthcare, whether you're talking about mammograms in certain states or you're talking about screening people for diabetes, which still can't be done in most places. That very tight coupling between physicians. I'm a physician. I love being a physician. I love having a chance to care for people. But if you require so much care to be dependent on having a physician and a physician ordering it, it's going to be very challenging. And that's a huge challenge that we deal with. And the other component of it is sort of this lack of systems, right? I mean, one of the most sobering moments for me in the pandemic was the first summer when in my area, the public health community finally got control of COVID and things are sort of springing back to normal. I went to clinic on a Friday and I could have sworn that my EHR was broken because when I pulled up my schedule for the day, I had one patient for the entire day. And it was a sobering moment because, yes, COVID has gone down in our area, so I didn't have as much COVID cases, which was a welcome. But at the same time, I knew there were so many families that had deferred care for many months, people with blood pressure and mental health issues, but they didn't come back. And that's because we don't have systems for chronic and preventive care. We typically wait for someone to show up and then we do our darndest to help them. Well, we don't have systems that say, well, you haven't been in for 3 months or 6 months. Let's make sure you come back in. And sort of sitting there in clinic idling that day was a stark reminder for me of how desperately we need those systems. And certainly, I think we saw some of the core structural elements, right? The disparities we see in health and healthcare often mirror the disparities we have more structurally in our communities and our society. Clearly, all of us have been battling mistrust and misinformation, and clearly the historic lack of investment in public health. So all of these were massive magnifying glasses, but hopefully it starts to paint a picture for some of this is in our control. Some of this has to do with how we've designed our systems, whether intentionally or unintentionally. All right, so that's the bad news. But a lot of really good things happen. And I think that's an equally important story for us to understand, because if we don't understand that story, we're not going to be able to make the right decisions, going forward. So what accelerated? So I know that this is a forum where folks are passionate about telehealth. And so it's not a surprise that one of the big trends that we saw was how care became virtualized. The picture on the left is one of my first telehealth visits. My 7-year-old jokes with me. She's, or not jokes with me. When she first saw this picture, she said, "Wow, Papa, you have a really big cell phone in clinic." I don't think she's ever seen a landline phone before. But that's how we did telehealth visits. It's just an old phone, and it's all audio, generally speaking, in our clinic. But we had never done it before, and it was transformative. I think we could all exchange stories of how much we were surprised by how good it could be. I think for me, one of the most sort of sobering realizations is, even though my clinic is in the community and we try our best to have access, the number of people I saw during the pandemic who I was the first doctor they saw in 5 years just blew my mind. And I'd ask them, I say, "Well, how's it I'm the first doctor you're seeing? I've been here for years now." And I said, "Well, doc, I can't get out during the day. I got to choose between, earning a wage and coming to see you. Now I can just call you on my coffee break, and here we go." So I think that's been really profound. I think a lot of us, if we all talked, would say, mental health was a real surprise. I remember when I did my first mental health visit, I was like, this is the absolute worst thing I could be using video visit for. But you know what? It actually was the best thing. It was very interesting. We were on FaceTime. I felt like we were equals. I felt like, the patient was able to be much more open with me. She didn't have to bear the stigma of walking in clinic and the front desk asking her, why is she here? Well, she's here because she's having postpartum depression. It was really curiously intimate, and I think really well received by the patient. And so I think we've learned a lot from that. And part of it, the virtualization, is also the use of community. So this is what our testing site looked like. It's a white tent and a nurse with a megaphone. It's not that complicated. But part of the question I started asking myself is, wow, this makes so much sense. Why weren't we doing this before? Why is it every flu season we make people come in who are sneezing and coughing, make them sit in a place that we actually call a waiting room, so they can sneeze and cough on each other, just so they can come see me and sneeze and cough on me, just so I can order a test that we could have done in their car, right? So why do we do those things? And I think, it can be as simple as a white tent and a megaphone to solve it. We didn't need regulation. We didn't need payment changes. Actually works extremely well in a fee-for-service environment. So these are some of the innovations we saw and that you all scaled as well in your communities. Virtual's gotten a lot of the buzz, but that's not the only shift that happened. Care shifting into the home was massive. A lot of people, same reasons: sheltering in place, scared to go to the doctor, doctors weren't available. Home care increased dramatically. And home care can be defined broadly. I mean, in a way, telemedicine is a type of home care, but even doctors, classic Marcus Welby style, started getting back into people's homes. And it wasn't just physicians. We saw a proliferation of people providing ER level care, right? Because remember, people were scared to go in even when they had heart attacks. So, organizations started sending out individuals with these big trucks or big vans rather, that had X-ray machines and IV antibiotics and IV fluids and IV medications. And that became a real trend as well. And so again, this idea that, if clinics overwhelmed, hospitals overwhelmed, how do we start to distribute care more to where people are? And that was a huge shift as well. Another big shift was care into the community, right? So my clinic, for example, we've for years had a church almost across the street from us. We never worked with them before, but they became a vaccination site for us, right? So truly meeting people where they are, getting involved more at the schools. We started staffing a public health department. We'd never done that before. These are the kinds of innovations that we've seen scale and spread all around the country as we were trying to get shots in the arms or make testing more accessible. And I think those are really powerful things. Imagine, could we use that for the shingles shot? Could we use that for the pneumonia shot? Could we use that to go educate people about mammograms, right? So these are some of the ideas and some of the muscles we started building during the pandemic. But there's a lot of missed opportunities for sure as well. When New York was hit really hard, and I think all of us, if you can remember those graphic scenes and those stories of families that were separated, couldn't be at the bedside with their family members as they passed away or had some of their most challenging days of their lives. absolutely heartbreaking stories. My colleague and I wrote about how, well, this is the moment to scale hospital at home. For folks who don't know, hospital at home's been around for 20 years, proved in multiple clinical trials. There's a Cochrane review, but we just haven't scaled it meaningfully. And so we put people into tents. We put people in tents in Central Park. We put them in boats. We put them in makeshift hotels. Why didn't we put people at home? And so fortunately, we were able to push through and get a small Medicare waiver for some pilots, but we really didn't scale this at the speed that we needed to really serve the massive need that we had, and so much heartbreak, I think, because of that. Another really positive thing that happened, and this is really important, is sort of the demand for change, right? I think, we saw these stories of people that went into the ER and, got a $10,000 bill for a COVID test, and people went to social media to sort of complain about it. And that led to, that bill being reversed or taken away. I think, for those of us that work in healthcare, so much of what we do seems kind of behind the scenes, and the frustrations we have, we feel like we're the only ones that know. And I think this is really important. Almost everyone in this country has the visceral experience, the lived experience of what is it like to try to get a test? Or what was it like in those early weeks hitting refresh on your web browser, trying to get a vaccine appointment for yourself or for your parents or for a loved one? And that's been the experience of healthcare professionals. That's been the experience of some of our most marginalized patients. But now it's a lived experience for almost every American. Almost every American on some level understands, how fundamentally inaccessible and broken the system is. And that's a really powerful thing. That's a really, really powerful thing. When people understand and have an experience that's shared with you, that's a really powerful thing. And again, well, what are we doing with that? What are we doing with all these things that were accelerated? That's the question. So there's a lot of debate. You guys are probably far more brushed up on what's happening in Texas than I am, but there's lots of questions. What's going to happen to scope of practice? What's going to happen to licensure across state lines? What's going to happen to telemedicine payment? Those are all great questions. I don't have any crystal balls, unfortunately, even though I live just 10 minutes away from this place called Washington, D.C. I don't have a lot more insight. But what I do believe, and this is really important, is that, at the surface are these policies. At the surface is reimbursement. Of course, it's important and it makes a huge impact. But beneath the surface, there's a seismic shift happening. There's cultural change that's happening. And those shifts, I think, won't reverse quickly. In fact, I think they'll last a generation or more. And that's really important, right? So the first one, right? Physicians. I think most of us, I'll admit it, I thought that telemedicine was sort of a last resort. It was, okay, well, it's not as good as in-person care, but hey, if there's no other choice, let's just go ahead and do it. But now physicians are increasingly trusting care. One of my mentors at Hopkins told me, he said, medicine moves at the speed of trust. Medicine moves at the speed of trust. We've had the technology. In fact, the technology for doing telemedicine, I don't know if you guys know this story, but the first phone call between two human beings in the world, Alexander Graham Bell, was actually about healthcare. You guys know the story about how he had set up the first telephone and then the battery spilled on him. And so he called his colleague and said, using the telephone he invented, and said, come over here, I spilled some battery material. I mean, that was a telehealth visit. So the technology has been around for a long time. We've been using it in the VA. We've been using it in a lot of different places for a long time, but trust was the missing element. And I think, again, through lived experience, a lot of us trust it. We don't think it's perfect for everything, right? I don't think that's the point. The point is that it's another option. It's an equally valuable option depending on the patient context. And that's really huge. The same is true for the patient side of it, right? Like, I had never done a telemedicine visit. I don't know how many of you guys had their first one during the pandemic. I had my first one. My 5-year-old had her first one. And hers was really interesting. My 5-year-old, she's one of those kids who every time she goes to the doctor, I think the doctor must think she's like totally behind, because she's just grabbing onto my pant leg the whole time. And, she's trying to engage her and say, well, how many colors do you know? And how many blocks can you put up, right? I'm not a pediatrician, whatever the pediatricians are doing. Well, she had a video visit during the pandemic because we had to. And when the doctor again said, well, Leela, can you show me, like, or tell me how many blocks you can put or what, she runs out to her playroom, which is right over here, grabs some fantastic recent Lego creation, showed her doctor, and was telling her all the different colors and all the different things that she put together. And I think the doctor must have been like, wow, I think this kid had a development spurt, but she didn't. It was, care in a clinic for her didn't make sense. Just like adults have white coat hypertension, my daughter had an aversion to being in a clinic, and actually being in her own environment, she was able to be her full self. And isn't that important for healthcare? And so I think patients too learn to trust care outside of a clinic or hospital, and the data bears that out as well. Health systems too are shifting. That's sometimes the hardest thing to shift as someone who's spent time building ACOs and value-based care models around the country. Very difficult to do, but I think part of what they saw, frankly, was the financial impact, right? If you are operating like a restaurant, fee for service, you're operating like a barbershop, fee for service. Well, guess what? If there's a pandemic, if there's a flood, if there's from the threat of climate change or a security breach, whatever you have, guess what happens? Your revenues drop. And so there's a lot more interest now in value-based care, maybe not for the right reasons, but recognizing that there's a huge financial risk to fee for service. We're seeing policymakers shift as well. I think a lot of them, as I do get a chance to go into DC a lot, and I do some work with the AMA and other groups, I think they were really surprised, right? Like, we were surprised that, we suspended HIPAA. Remember that for a little while, and we could use WhatsApp and we could use FaceTime. I'm seeing some head nods. And guess what? We didn't have all these crazy privacy violations. Patients didn't put their hands up. I remember my clinic, we were really nervous because, we take care of some low income folks. So we decided to use WhatsApp. And, so early on, I was nervous. So I asked every patient, I said, just so you know, this is not a secure form of communication, but, we can use it if you want. And they're like, I want to see the doctor. I'm not worried about, they're exchanging banking information through WhatsApp. They're talking about their deepest, darkest secrets with their friends and families all over the world. They're like, come on, I want to see the doctor. I'm not feeling well, right? So I think policymakers, saw that as well. I think certainly health equity. I had a chance to talk to the new head of CMM, the Centers of Medicare Medicaid Innovation recently, and not surprisingly, although it hasn't been like that in the past, health equity is top of mind. They're not going to do anything that also doesn't advance health equity. So I think that's a really important set of changes. I can't underemphasize it. That doesn't go away. Trust doesn't go away overnight, right? So regardless of what happens at the surface level, I think this lived experience and these sort of cultural shifts are really important. Okay. So health, COVID magnified some really major challenges, right? This wasn't just about COVID. These are about deep failures of the healthcare system that pervade, routine and usual and chronic and preventive care. At the same time, driven by necessity, we've had an incredible amount of change at the front lines, which is often the hardest but most important changes to come by. But where do we need to go? We're not done yet. So where do we need to go is the question. So I want to start with an anecdote. That was a quick picture of my mom, but so I actually became a doctor because of my mom. When I was in middle school, my mom, who was my whole world, like so many of us, I was diagnosed with type 2 diabetes, and I was just a kid. I didn't know that much about it, but I knew that it was a life sentence. I knew that our lives wouldn't be the same. And so that's when I decided I want to be a physician. And my mom, 25 years, she's had type 2 diabetes, and as a son and as a doctor, always, was like rubbing salt into a wound, which is that my mom's diabetes was never controlled. And 10 years ago, she was started on insulin, and she's been on ever increasing doses of insulin. And again, her blood sugar has never been controlled. But early in the pandemic, if you remember, all the early news stories were like, hey, if you have diabetes and you get COVID, your COVID's going to be worse. She was scared. And she decided that enough was enough. So with my help, she found an online service. She signed up. The next day, she got a glucometer and a ketone measuring device sent to her house. She got connected with a 24/7 coach, a nutritionist who guided her through a pretty aggressive change in her nutrition schedule. She had a virtual endocrinologist who titrated her medicines, sometimes every 2 to 3 days in the early weeks of the program. Very importantly, my family, we're from India, and my mom's a vegetarian. So they connected her with somebody who was 5 years ahead of her in the program, a gentleman who lived in Chicago, halfway across the country, who, you know, she could swap recipes with to try to figure out, how do I make this diet work in the way that that I can still enjoy my food. Well, the net result of that was, you know, 25 years of type 2 diabetes, 10 years of increasing dose of insulin. My mom was taken down from 25 units to 10 within 2 weeks. Within 2 more weeks, she was off of insulin. And, you know, now it's been 15, 16 months and my mom's completely off of medications for diabetes and her sugar is completely controlled. And that's the kind of change we need, right? So that's my mom. She's lost some weight too, and she's living her best life. And that's what we need to do, right? It is the last thing we wanted to do for my mom was, you know, if you take diabetes care, we take, you know, you see your doctor, the doctor does the best they can. They give her a bunch of things to do. And then guess what? Then they don't see her again for 3 months or 6 months. And in the interim, there's really not much. Maybe she sees a nutritionist one time. Maybe she, you know, gets a referral to an eye doctor one time. But if we just take that model and make it virtual, we're not really going to get the outcomes, right? It was the fact that my mom had that 24/7 coach. Her medications would be titrated. She had the expertise of that care team. It was all of those things together that finally, after 25 years, she was able to go where she needed to go. And that's really, I think, the main point of this last section is we got to, you know, I know there's a lot of terms, disruption and reimagine, but that's really what we're talking about, is we have to change the care models, leveraging technology. We can't just use the same models and just insert technology into them. So what does it actually mean? You know, and so, you know, in putting together this book that sounds like you guys had a chance to take a look at, that I was very purposeful around creating this framework, which when I presented to the AMA, they immediately called it the 3Ds, which that was not intentional, but is that care needs to become distributed, digitally enabled, and decentralized. So what do I mean by that, right? So distributed means we need to meet people where they are, right? So I don't like the term virtual necessarily. I don't like the term home-based care. There's nothing wrong with it, but the point is we need to meet people where they are. Now, some people where they are is online. That's where you want to meet me. But some people that's at home, some people that's at church, some people that's somewhere else. That's the point. And so we need to distribute here. But the other part of the point is that sometimes virtual isn't enough. We all know that. Sometimes home-based isn't enough. And so distributed I like because it connotates that it's connected, that we might distribute, you know, the front line of primary care to your home, but that, you know, as you might need to go up and down the system, you might need to come to clinic or go to a hospital and come back, it's connected. Digitally enabled, right? So I think, again, purposeful about the words is that, you know, a lot of physicians with the EHR don't have a huge love for technology. And then we hear this looming threat of AI. I think what we learned during the pandemic is that the real role of data and technology is to strengthen relationships, right? Again, medicine is built on trust. How can technology do that, right? When I text my wife during the day, my wife's a busy oncologist. It's not because I'm trying to replace her or use automation or bots, right? It's a way that we can more efficiently communicate. And we saw that through the pandemic. I got a lot of emojis from patients during the pandemic. It was really nice. Never had that before. And then decentralized is this idea that, yes, value-based care is great. It's a pricing model. It's a payment model, which most doctors, their eyes glaze over when you start talking about payment models. But decentralized is the point that you have to move the resources to the front line. So the example I oftentimes think about is, I had this amazing patient of mine who was, you know, in her 70s, in and out of the hospital with heart failure. And after one of the hospitalizations, I saw her and I said, hey, remember, check your weight. If your weight's up a little, give me a call. And that day, I don't know what got into me, but I asked her, I said, do you have a weighing scale? And of course, she looks at the ground and says, well, I don't have a weighing scale. And, you know, I rummaged the clinic looking for a weighing scale, couldn't find one, ended up handing her $20 out of my pocket, and she bought a weighing scale and never got admitted again. And so decentralized is this idea that, like, look, if I wanted to, she had Medicare, if I wanted to admit her to the hospital for heart failure, I could do that and probably rack up a few $1,000s. If I wanted to get her a cath, probably could have done that. I probably could have put her on some crazy heart failure medicine. But if what I needed was a $20 weighing scale. And so who knows that? Well, I know that, and the patient knows that. And so decentralized means we need to put resources in our hands so that we can best steward those resources. And value-based care doesn't necessarily do that. Value-based care sometimes moves resources from some health insurance company administrator to a health system administrator, and to a doctor and to a patient. That's kind of the same thing. What we need to do is really put the resources in front of people. And so, you know, these are just concepts. I mean, again, distributed, a big part of distributed to me is like as I've said a few times, is an equity argument, right? That if you really believe that a lot of people live in health professional shortage areas, a lot of them can't get to the doctor, they don't trust the doctor, they can't afford a doctor. The moment that everything in the health system requires a doctor, you've lost a bunch of people. And in fact, you've lost the people who need it most. And that comes up all the time. So this was the example I gave earlier. You know, again, we wrote this March 16, 2020. Now we're talking about giving people free home tests. But, you know, that was really the core idea. You know, when we were scaling up drive-through testing, that's nice, but not everyone has a car. Not everyone lives in an area dense enough to justify having a drive-through testing site. Early on in the pandemic, we could have had a model where we were mailing people tests and created, again, a place where we're meeting people where they truly are. And think about the impact that might have had on the course of the pandemic. Digitally enabled, right, is this idea that the idea of putting the technology in a way that strengthens relationships. Part of the relationships is between the patient and the doctor, absolutely. But part of the relationship is between doctors and doctors. And I see the big Echo sign behind you guys sitting there. I'm a huge Echo fan. I think that's an example of the kind of technology that we absolutely need to have. It's a different kind of digital enablement to really strengthen those relationships between each other, which I think is equally critical. And then decentralized. So there's a lot of components of decentralized, but this was a piece we just wrote, I think in the past week or so. But, you know, again, it's a good case study, right? We have these 2 new antiviral pills that are going to be approved soon. It's incredible the impact on mortality and hospitalization, particularly the Pfizer medication. But there's a problem. The problem is that, you know, incredible biomedical discovery, I probably can't even explain to you how it all works, but the point is that you need to be prescribed this within 2 to 3 days. So what does that mean? Well, what does that means is that you have to recognize you've been exposed or had symptoms. You need to then call and make an appointment and get an appointment within a couple of days. You need to take time off of work to get to your appointment within a couple of days. The doctor needs to be able to know that you get this thing. You need to be able to go to the pharmacy and afford the medication and start the medication within 3 days. That's a really hard thing to do. And so there's all these, you know, New York Times saying, oh, well, death from COVID is going to be over thanks to these new medications. And I'm sitting there like, what? Like, so how are we going to do this? How are we going to do this? And so this is this idea of just decentralized, and it's a little bit controversial, but part of what I'm saying here is, look, if public health departments are doing contact tracing, maybe we need to allow them, if they're already tracing people and testing them and finding out they're positive, maybe we need to allow them to dispense the medicine. Because right now what's going to happen is the public health department, oh, by the way, you have COVID, go see your doctor. And the clock starts, right? And so these are some of the decisions we have to make about how we design, you know, care. I give the analogy when I was advocating for at-home testing. Imagine if women had to see a doctor and get prescribed a test for pregnancy. Just think about that. Think about that. If you had to see your doctor in order to take a pregnancy test, what would happen? What would happen? How many people would miss their prenatal visits? How many people wouldn't start cutting down on alcohol use? How many people would, right? Like, go on and on down the line. Mm-hmm. And that's the case right now. A lot of people with diabetes don't know they have diabetes. A lot of people with HIV don't know they have HIV. So we have to start thinking about these things, and we have to start thinking about things outside of our clinic. Otherwise, we're going to keep perpetuating the same problems that we're in. I can talk forever, by the way, you could tell. I want to make sure I'm leaving enough time for Q&A. So let me try to wrap in 3 or 4 minutes here, because I'm excited to get into the questions. I think the first is, especially for this audience, which is passionate about telehealth, I want to sort of give an analogy, which helps me think about this, which is, think about banking, right? Back in the day, you had to go to the big old bank and get your banking there. Then we had ATM machines, right? So it's more distributed. You can kind of get your withdrawals and things like that closer at home. And now it's amazing, the technology, you can scan a check. I still don't know how it works. Scan a check and somehow deposit in my account. Well, and people have used this analogy for telehealth, right? You had to go to the clinic or the hospital, and then now you can kind of get at-home testing, or go to Walgreens, and then now you can do a bunch of stuff on your phone, right? Same thing. Well, there's a problem. Imagine when you go to the bank and you go to the ATM and you say, I want to withdraw $100. Imagine if the first question it asks you is, how much money do you have in your account? Or imagine if you go to the bank and you deposit a check for $100 and then it says, thank you so much for depositing the check. Can you fax us a record so that we can update your account? But that's been the experience, right? People that go see, particularly telemed services that are standalone. I don't mean based off a clinic like you guys are doing. If you do a standalone company, like let's say Teladoc, that's been their experience. They call, there's no record at all. They're not connected. They can't prescribe medications a lot of times. They call the next time, it's a totally different doctor because each doctor only spends 2 hours on the system a month, right? So this is the problem. Telehealth's really promising, but how do we start to actually deliver it in a way that meets patients' needs and can meet the needs of chronic care and more comprehensive care? This is also really important. You know, as care gets distributed, one of the concerns is that it becomes more fragmented. And so it's going to be more important for these services to be connected. Right now, it's a nice to have because generally health systems are kind of their own, you know, castle on a cloud, right? But as we're moving to a world where, okay, you're getting hospitalized at home and you're getting a test at Quest and, you know, your primary care doctor is virtual, but your specialist is brick and mortar, it's going to become an imperative that we connect these services. And that's going to be really important. I'm not going to go through a lot of detail here, but the point is that care has this opportunity to become more continuous, right? Go back to my mom's story, right? It's not just the first step of transformation, which is, hey, let's make it's more convenient, which is great, by the way. Convenience is important. But the second part is, well, how do we start to make this more continuous, right? How do we start to look at your glucose data, look at your blood pressure data, right? Get more frequent communication. But then ultimately what we have to do is really get to outcomes. And in my mom's case, reverse her diabetes, but there's lots of other examples of that, right? Where we got to start de-escalating care, doing much more behavior change, right? Like that's really where we all need to go. I mentioned Echo. I told you I was a fan. I wasn't just kidding. That's Sanjeev Arora, who helped create Echo on the left. But you know, I really do think that tools like Echo, some of the clinical decision support, I think we could finally, you know, speed up the time it takes. And again, this is the kind of reinvention I'm talking about. If we just do care virtually the same way we do brick and mortar, we're not going to speed up that time. We'll speed up that time if we find new ways of connecting each other like Echo does, and we'll find ways of putting data in front of doctors so that we're making evidence-based timely decisions. I'm gonna watch time here. All right, so I'll sort of end with 3 specific recommendations. So the first is that, you know, on the disparities point, I think you kind of hear all these different things. You're like, well, telehealth's great for improving disparities and telehealth's horrible for, I don't think either is true. What is true is you have to design your system to be inclusive from day one, right? And it's possible, right? Like we can train people and improve their digital literacy, right? We can make sure that the people that are staffing our virtual visits are more concordant, meaning that their look and act more like the community that they serve, right? We can do those types of things. And if we do that explicitly and with intention, I do believe that digital has a huge potential to be able to improve disparities, but it won't happen by accident. It won't happen as a secondary impact. You have to explicitly design with equity in mind. On the design point, and again, I'm not going to go through this in detail, but I think something that we all have to learn as a core competency is user-centered design, right? So a few months ago, my daughter was 7, my older one, she was having difficulty breathing one night. And so we called up her pediatrician's office and it said, you know, call 911 if it's an emergency. And the second thing it said is leave a voicemail for $25, right? So if we don't think about the experience of care from the user perspective, and we don't think about every single step in that, you know, we were sitting there saying, well, okay, I don't mind paying $25. We're fortunate to have it, but how long is it going to take you to get back to me? Right. And maybe on their end, they had this whole sophisticated system to get back to us in time. But for the user experience, it wasn't at all clear. And so we ended up doing something else. Right. So you have to think about all those steps and really think about user-centered design. And then the last one is leadership. You know, healthcare is complex. I think one of the most amazing things that we've seen is incredible leadership from the front line of healthcare, right? Like after years, if not decades of being marginalized, doctors, nurses, pharmacists, we are leading the way in healthcare again. And maybe I'll end with that as my last thought. And I'll admit this is optimistic, but if you think about, World War II, right? Global tragedy, hundreds and hundreds of thousands of people died, economic turmoil, families, lost or divided. But what came out of that, right, from this global war, right, was this idea of universalism, right? You started to see institutions like the World Bank get formed out of it, right? You started to see incredible amounts of philanthropy happen, right? You started to see sort of a much more global consciousness in the way that people operated. And again, it's our choice. I don't think we're there yet, but I think I see the potential for us as well, right? I see that global tragedy, we've lost a lot of doctors and nurses, some from COVID, some from their own hand. But I've also seen these incredible muscles be developed, right? Us changing protocols weekly as vaccine guidelines change, us partnering with churches and community resources, us using data in new ways, us using telemedicine. And I see in doctors and nurses, those that are still resilient and standing, a change in their mindset. They're seeing that they have a role in serving the public. They see a much more expanded opportunity for them to lead. And so I guess I'll leave you with this last thing as we transition to the Q&A, which is that I do believe that there's a potential for us to be medicine's greatest generation and to finally heal the system that brought us into our calling, and that I think gives us purpose and meaning in the work that we do. So thank you so much for the opportunity to come and chat with you all, and looking forward to the conversation as well. Thank you.
Thank you very much, Dr. Nandi. That's an excellent talk, Mr. Majors. Dr. George, any question from the crowd, Mr. Majors?
I think it was a wonderful talk, and we so much appreciate you coming our way. I know people in the audience enjoyed it. We represent on this audience a number of different groups and entities. I want to ask a question about education. I think some of the educational accreditation agencies and so forth may not have caught up with all this. And when we're educating young people for careers in healthcare, be it as a physician, nurse, therapist, and so forth, there are generally so many encounters that are required that are part of the learning experience. And I think some entities have said some of these visits will not be allowed. What are your thoughts about this, what you're talking about all morning or during the session, and how we address that from an educational standpoint to help the learner?
Yeah, it's a fantastic question. I'd love your thoughts as well, as folks who do this day in, day out. But from my perspective, right, in medicine, when we're training, we're trying to learn kind of two very distinct things, right? One is we're trying to learn sort of the science of medicine, like the theory of medicine, right? The biology, the chemistry of medicine. And the other part that we're trying to learn is the practice of medicine, the delivery of medicine. And sort of my contention is that I think our academic medical centers and universities are really great places to learn the first. They may or may not always be the right place to learn the second, right? That if you want to learn how to deliver really good virtual care, or you want to learn how to deliver home-based care, some academic centers do that and do it well, but some of them don't. And I think part of where my head goes is you always want to learn from the best. Imagine having people go to something like an Oak Street Health and learning how to do primary care, or having an opportunity to work at a telemedicine organization that does primary care, or work in a community health worker community-based model. I think that's something that we need to think about, because it's not one size fits all, and it's hard to be great at everything, and you want people to learn the right habits in the right ways from the best places.
Thank you very much, Dr. Nandi. I have a question though. We are doing telemedicine in our institution, and we're doing a lot of telemedicine, but we want to be better. We want to optimize, the delivery of telemedicine. As an academic institution, do you have some advice for us, some recommendation? And what do we tell those physician providers who are still doubters of telemedicine who are apathetic to telemedicine. There are a bunch of those too.
Yeah. Well, let me start with the first. I mean, look, I think that, when we talk about, creating and fulfilling the purpose that brought us into healthcare, I do believe that, all of us have to find our people, and we have to find the way that we want to care for people. Right. And so I think, yes, you might have some doubters, and on some level, there's things you could probably do, but I think on some level it's okay. Right. Because I think some people, they love to work in people's homes. Some people are going to love to work in a clinic. Some people are going to love to work in a high acuity center. And I think part of our job as educators is to help people find their mission and to help them actualize in the way that they want to do things. Right. I think some of the mistakes we make is like diabetes is an example. I love diabetes. I could take care of people with diabetes every single day of the week. And I have colleagues who that's like an anathema to them. That's like, they dread every diabetes. Well, why is it that just because I'm in primary care, why can't I declare what it is that I'm interested in? Because doesn't the patient have a better experience and better outcomes when I perk up because I'm excited to take care of their diabetes versus helping, somebody with some other issue that maybe is not as passionate for me. So I think that's something that we have to think about is how do we create that kind of specialization and how we want to practice. On the first, wow. I think that there's no shortage of opportunities. I think where my head goes, just because of my bias, is chronic care, right? Like, how do we, really, like going back to my mom's story, start to do things that are truly transformative, right? Like, how do we leverage telemedicine to have more frequent checkups with maybe a nurse or a medical assistant, drive that more frequent coaching, understand people's home environment, maybe take a video into the kitchen, show me your fridge, show me what kind of foods you have, right? Like really getting into some of the root causes. I think that to me is a pretty exciting area, but there's many exciting areas of exploration for telemedicine.
So Dr. Nundy, this is Lori Ross Spearman. You touched a little bit on one of the areas that I wanted to get a deep dive in with you, because you've done a deep dive into this area. We are trying to do what we call a comprehensive approach to telehealth. We're going to look at the academic preparation throughout all of our patient-facing academic programs, whether it be clinicians, residents, physician assistants, nursing, OT, PT, AT. We're running the gamut on embedding this into our curriculum. Second, we're trying to build a virtual platform. We are spread out across 6 campuses across all of West Texas. The geography of West Texas is larger than some states. And so we're working on what that virtual platform looks like. The third area where I wanted to touch base with you is we want to be the university that individuals turn to for evidence-based research on the efficacy of telemedicine. Do you have any thoughts around studies or areas where you think that we could dive into initially? Because we'll need to focus our initial research and put some dollars there to really show some immediate impact of telehealth.
Wow. I first of all, I love the overall vision and ambition. Like I applaud you for that. Here I am talking about leadership and look what you guys are trying to do. So that's incredible. That gets me fired up. Man, I think the research questions are many. It was mentioned in my bio that I'm a chief medical officer at Accolade. We actually have 200 practicing physicians, and we do virtual primary care nationally in all 50 states. And I will tell you that, like, to me, I feel like we're just in the first innings, right? Or maybe first yard line. Like it blows my mind how many questions I have, right? So from, okay, if you take someone that doesn't have digital literacy, how do you actually improve their digital literacy so that they can use, telemedicine the way you want? I mean, from that question to even we have basic questions like, when I'm managing someone's blood pressure and they're taking it themselves, what's best practice for that? Like, should they measure it themselves? Should their first measurement be like on a call with one of our nurses so they make sure they're sitting for 5 minutes and their arm is here and they're measuring their blood pressure? I mean, I could go on and on for how many questions I have. The experience, like when you talk about trust, like people haven't really measured that. Like how can you engender trust through a virtual means? What matters? Is it the lighting? Is it your code? Is it the length of the visit? Is it, but I think trust is a very early important outcome when it comes to primary care that we need to be able to assess and drive toward. I mean, I can keep going. Like another example is collaborative care. I'm a big fan of the collaborative care model. How do you deliver the collaborative care model in an all virtual setting? I actually think it's a huge potential, but how do you do that, right? If you go back to the University of Washington research and how they did, how do you do that in a virtual world? So I think that you're absolutely right. You're going to have to prioritize. And just in my experience, I always prioritize near-term stuff, because I think sometimes we're like, oh, well, how do we get people to reduce hospital readmissions? I mean, I'm like, how do we just get people to use it, love it, and come back? And then after that, it's second order. How do we get people to, to get people on the right care path? And then after that, how do you start to get to outcomes? I tend to sort of always hyperbolic focus on, near-term, measures like trust, and then sort of work my way up.
Dr. Nandi, your today's talk was very eloquently spoke on the distributed care. And I really liked the way you had a very practical and I think a common sense approach to this entire pandemic, COVID-19. My question to you is if, for example, when your company, when you found that this pandemic was there, how did your company make changes to adapt to this COVID-19?
Yeah, well, first of all, thanks so much for your kind words. For us, it was a lot of different things, but really the main thing was, we serve employers and their families, all around the country. And I think for us, we looked at it very opportunistically, like we saw that mental health was an increasing problem. So we decided that we were going to hire our own therapists rather than simply navigating to their own therapist, right? We saw that, primary care access was getting even more challenging. And so we said, we're going to deliver a purpose-built virtual primary care service so that it wasn't just a complement to brick and mortar care. It could actually be, your primary care physician could be all virtual. And so we sort of decided that we were going to do that. And so I think for us, the short answer is kind of like I described where we need to go. We just decided to make a bet on that. And we said, we're not going to stand still. We're not going to make small changes. We're going to make huge changes and really co-create that future. And it sounds like you guys are doing some of the same things.
Nandi, we have a question from Natalie Conley. Natalie Conley.
Yeah.
Yes. Good morning or good afternoon if you're on the East Coast. So I work for a telemedicine, a nonprofit in Texas, and we specialize in HIV care, HIV prevention, and gender care. And something in your talk that was really thought-provoking was your patient who you bought the scale for. So we found that a lot of the social determinants of health and doing some basic motivational interviewing, we have these care navigators that they're this special team. After you see your provider, physician, you speak with them and they identify, hey, what's going to prevent you from taking your medication? And can we help with that? So that might be getting people housing, legal services, kind of anything in between. And that it's really helped a lot of our patient outcomes. I'm wondering, do you see any systemic changes coming to telemedicine that support that extra step? So it's not relying on the kindness of someone like yourself to give someone the money for a scale, where we can really support patients on that larger systemic level to get them that extra step that will ultimately make outcomes better and oftentimes reduce costs across the system.
Yeah, no, absolutely. First of all, love the example you gave. Like we have navigators as well that bookend our visits for the exact reason you're saying. It's the right thing to do, right? To get to, everyone talks about social determinants, you're actually doing it. But at some point you got to think about how are you going to do that sustainably, right? And I think that, as a country, we got two paths forward, right? There's the fee for service model, which is basically a Chinese menu. And you say, well, let's add a whole new section of the menu, which is navigator visits and, these visits and that visits, right? The other world, or, weighing scale visits or whatever. The other side is value-based care, right? Is to say, hey, we're going to get a certain amount of money per month or per year or a certain capitated payment. But again, my point is, like, even if we move to that, which is absolutely the right answer, by the way, is how do you actually put those resources, almost like a petty cash account, for the frontline providers to decide how those resources are shepherded. And if we don't take that extra step, I worry it's just going to be some version of financial engineering. So you're on the right path. I think my advice is move upstream, see if you can talk to, whoever's funding ultimately the care for those members, and then figuring out if they might be willing to fund it in some way, shape, or form.
There's a last question from Dr. Alokidi, and after that, we'll give it to the Office of the President for closing remarks. How do you merge reinvention effectively with collaboration? And who is responsible, and how will the positive shifts observed during the pandemic be sustained?
Yeah, it's a great question. I think one of the things that's been amazing, I'm sure you guys have all felt it, is I think we've never been as collaborative as we've been in the past year and a half. Like, we didn't even know which way up was. We got the new vaccine guidelines, and then we had to figure out what to do. Then the next week and the next week, and I feel like the level of collaboration and sort of and then out of that innovation that's happening on the front lines is unprecedented. I think the real question is, how do we sustain that? And to me, I think part of it is this vision that I'm trying to paint, which is say, I think in celebrating it and sort of taking the moment to look back and say, guys, look at what we did. And how did we do it? And then what is the next problem and the next problem? This was all driven by necessity. Now it's up to us. Now it's up to us to sustain that leadership forward.
Well, Dr. Nundy, thank you so much on behalf of the Texas Tech Health Sciences Center for coming in and visiting with our group. One of my dad's favorite sayings is, a ship can't set sail until it raises anchor. And I think we're at a pivotal point in transforming healthcare where we've got to figure out what these anchors are, raise them, and get going. So thank you so much for your book that has really set off some great conversation within our team.
Oh, such a pleasure. Thank you so much. Thank you guys for this opportunity to come talk to me today.
Well done.
Thank you. Thank you all.
Yes.
So from the ECHO project at Texas Tech, we have an exciting teleseries for 2022. And so please look forward for our usual mails, and we will have excellent speakers on board. And so I would invite all of you to be there for this teleseries. Thank you. Have a good day.